for the next month continuously because of her jaw-dropping discussion yesterday. Truly draw off the floor. Today is really, really special. It's special because it's not every day that there is a groundbreaking innovation in the realm of clinical reasoning. You know, it's a slow-moving field that often relies on slow iterative expansion of the people within it by exchanging ideas and concepts and thoughts and cases. And, you know, very, very rarely does somebody just offer something that allows all of us to rapidly accelerate our growth. And I think today is that day where we get to share that tool. It's even more rare, I would say, for one person to almost single-handedly be behind such a project. But today we're graced by the presence of a person with said project, and his name is Travis Zach. He is a UCSF HEMONC fellow, a former resident who had to suffer through months of working with me, somehow made it and has created an incredible tool that we hope to showcase today. So the format is going to be a little bit different. We're going to try to utilize this tool in real time to best show you how it works. And we'll try to save some time at the end for questions that you have about the tool. So today is less about the cases itself, but rather how the tool helps you pick cases and train your clinical reasoning mind. But without further ado, I'll pass the mic to you, Travis, to say hello, and to just jump right in and show us what you got.
Yeah, okay. Thanks so much. That was like way too much of an introduction. The way I introduce this tool is I actually I was working as an intern under Robbie and asked him ways that I could increase my meaningful reps, and he recommended case series like the New England Journal CPC. But one thing that frustrated me, working long hours as an intern, is when I got home, I wanted to learn on cases that were based on patients I had seen, right? So if I had seen a patient with shortness of breath, I wanted to read a case about a patient with shortness of breath or similar, right? And that's not always how it happens in random case series, right? And there is benefit to seeing a wide breadth, but when you're exhausted as a trainee, you often want to like streamline and synergize your learning. And so the goal with this is, I still remember going down to the ED is like, okay, what about this idea, Ravi, was how do we make it so we can find cases that will you can learn on top of cases you're seeing in the clinic. And so that was the goal, and that's what I'm hoping to showcase here. I want to just mention a couple things, right? Because this is a little different than a typical morning report. The most important thing is, these are not my cases. The cases I'm presenting are from the New England Journal. I'm gonna, I'll link directly to them. And so, this isn't my intellectual. These cases are fantastic, and one of the reasons I spent so much time on them is I think there's so much learning in these cases, and I just wanted a better way to access them. One other point I wanted to make is these cases are typically for more advanced learners, so don't get frustrated if the cases are a little hard to grasp initially. I think the target audience is interns or residents or maybe even fellows in a lot of these cases, so that the topics can be quite advanced. I think those are most of the things I wanted to touch on. So the way I was going to start is I was like, okay, I'm going to showcase the tool. What cases should we look at? I was wondering if I could share screen maybe or not. Yeah. And so I work in cancer. I typically see pancreatic cancer patients. It's kind of the specialty I'm in right now. And so can you see the screen? What do you see on the screen? Yeah. Do you see the website? Yeah. So I typed in to search. I was like, okay, let's find a case. This is the browser. Every single one of these dots is a case over the last 55 years. So 2,600 cases. And you can use the browser to say, okay, so like I said, pancreatic cancer. So the two things that came to mind were abdominal pain and weight loss as how we wanted to select. And so this will find all cases where these two symptoms were present within a case in the last 55 years. Now, we want to make this a diagnostic mystery, right? So it depends on how you want to use it, but it's important to click show final diagnosis. You want to hide that, right? Otherwise, you're going to know the diagnosis before you get to it. And then you can kind of just search. And this will kind of restrict the list both in the table and in the dots here to only cases where both of those symptoms were present. And the size of the dot represents how much those symptoms were discussed in the differential diagnosis. So, maybe the symptom was present, but wasn't really a salient feature for what was important in the problem representation, then that dot's going to be very small. Whereas if it was discussed frequently as part of what they were using to kind of narrow the differential, then the dot is a little bigger. So I think I selected this one. So it's a case from 2012, case 23, a 55-year-old man with abdominal pain and weight loss. And so here we can just go to the case. I put this, that's kind of on purpose because I want to make sure that you realize this, like I said, it is their property. I'm not trying to circumvent it. So you go to the New England Journal page to read it. So Robbie, if you don't mind, I'm going to just get started on the case. Like I said, I kind of condensed it a little bit.
Yeah, let's do
there's
it.
a couple spots. Okay, so a 59-year-old man was admitted to the hospital because of abdominal pain, nausea, vomiting, and weight loss. Patient had been well until 9 months prior when weakness and anorexia developed. Initial workup at outside hospital showed no lab abnormalities, including a normal TSH and a negative fecal occult blood test. His EGD was unremarkable, but biopsy of the duodenum found villous blunting, active inflammation, and intraepithelial lymphocytes, findings that at that time they thought were consistent with celiac disease. Colonoscopy revealed erythema in the right transverse colon without ulceration, and the colonic lamina propria showed marked colonic inflammatory changes. He was discharged with this presumptive diagnosis, but actually doesn't remember that diagnosis being given to him. So no changes in how he, any dietary changes. So 3 months prior to admission, his abdominal discomfort recurred with anorexia and 10 kilogram weight loss, progressing to diffuse crampy abdominal pain, postprandial nausea, and increased stool frequency. He represented and he had notable labs for normal LFTs, normal amylase, normal lipase, negative helicobacter antigens. His IgA antibody to endomycyl antigen was negative. He had IgA and Ig antibodies to tissue transglutaminase, which was also negative. And his other labs were mostly in the normal range. And we can go over them if you feel like it'd be helpful. His CT didn't show any obvious abnormalities. The patient was again diagnosed with celiac disease and sent home on a gluten-free diet. So there's a little more, and then of course we'll get into kind of the past medical and social determinants of health. But I wonder if you want to stop there, or if you feel like that's enough. Yeah.
Oh, geez. That is more than I can swallow. So I'll try to do this. But I will say that I think that it's amazing how you try to solve a problem with all the data that you have. And I think that the filter that you can start to apply is, well, what causes CT negative abdominal pain in a patient? And I think that is a prominent feature by which to analyze this case, because most devastating abdominal diseases show up on CT scan, especially those that are causing weight loss. And so if you start that as your operating framework of what does that, there's a variety of diagnoses, but I think that luminal causes like IBD as a prime example can do it. So the lumen hiding that disease is certainly prominent. And the reason to follow that lead is, of course, that there is luminal findings that were found before that CT. But you want to give passing hypotheses to the other categories of CT negative abdominal pain, which would be vascular issues like a mesenteric vasculitis, endocrine issues like adrenal insufficiency, and certain neurological issues that can cause CT negative abdominal pain, like acute intermittent porphyria or lead toxicity, none of which seem to be at play here. So I think the fact that this is CT negative and endoscopy positive reinforces the notion that the answer will be found in the lumen. But you have something a little bit more specific than that, which is you have findings consistent with celiac disease. And those pathological findings that you describe of villus blunting in the duodenum is very characteristic of celiac disease. Now, of course, that finding isn't unique to it. There's a differential diagnosis for that. But what you have here is something even more specific, which is that you have seronegative celiac disease, with the serologies are negative. So you can start to say, my DDX for this condition is my DDX for seronegative celiac disease. And the most common reason that patients have seronegative celiac disease is they have IgA deficiency. IgA deficiency is common in the general population. It's about 1% of the general population, but it's even more common in patients with celiac disease, about 10% of patients with celiac disease. So the way to bypass that is to check for IgG serologies. So in patients with IgA deficiency who have celiac disease, you check IgG serologies to gliadin and endomycin, and those will be positive. And that clinches the diagnosis of celiac disease. About 10% of patients are persistently seronegative celiac disease. They don't have any positive serologies. And the way you know those patients have celiac disease is they have tissue histopathology positive for antibodies. So those antibodies are not circulating in the blood, but you stain them in the tissue itself. And the thing about seronegative celiac disease is that it tends to be pretty severe, and it tends to affect older men more than others. So if we're in the space of, hey, I'm worried that this patient has celiac-like disease, but it's seronegative, I would check IgG serologies, and I would ask the pathologist to see if they can stain those antibodies on the tissue. That's a way around it. But there's a long DDX for things that look like celiac disease. And I think that checklist is to think about infections like Giardia and tropical sprue. Most notorious of which is Whipple's disease. That is a big one that does the exact same thing. So that's the kind of like short differential of infectious mimickers. Is it Giardia? Is it tropical sprue? Or is it Whipple's disease? There's a variety of autoimmune diseases that can do this too. We talked about seronegative celiac disease, but there's an entity called autoimmune enteropathy. It's something to think about in this situation, but it's a little bit less common than another autoimmune condition, chronic variable immunodeficiency, CVID. You always make sure that you're not being fooled by a lymphoma, because those lymphocytes that you saw may be malignant. So intestinal lymphoma is a notorious mimicker. The simplest mimicker to definitively exclude are medications that can do this. And we've had 2 of these cases on VMR already. The olmesartan or ARB-induced enteropathy can do this, as can mycophenolate. So what would I do next? I think the MedRec is going to be key here as a simple first step. And then the epidemiology of the patient will help us analyze if tropical sprue is at play or not. It has a very specific geographic restriction around the equator. But I would start off with the basic, is this seronegative celiac disease or not? That's tough one.
Awesome. Tough one. No, so what I actually love so much about these cases is we don't always have Robbie. And so you don't always have Robbie to train with. And if you read the case, the second part of the case is, of course, an expert giving you their working through of a differential diagnosis. And I will say that the expert in this case worked through it just like Robbie, right? So Robbie gave a perfect example. If he was the expert on this case, I think it was just perfect mimic, like redundancy there when you don't have Robbie. I'll say, so we have a little more, and I left out one key piece of past medical history because I was so excited to hear about, your differential there, that I think will be very helpful. So I'll go through that. And like I said, I'll do a MedRec as well. And then we'll kind of finish the case. So, but like I said, your differential and the differential in this case that was written are basically identical. So 1 week before admission, he developed intermittent bilious non-bloody emesis, which progressed into worsened abdominal pain, recurrent vomiting, and anorexia. By the night of presentation, he reported leg swelling, chronic constipation, but with increased stool frequency, and some confusion over what a gluten-free diet actually meant. He denied hematochezia, melena, hematus, and night sweats. So on past medical history, the patient did receive a surgical resection some 5 years ago, caused by neurofibroma of the jejunum. However, at that time, strongyloides were noted and the patient was prescribed ivermectin, though his adherence was unclear. Also had a hypertension and hyperlipidemia. He was Spanish speaking from the Caribbean, from which he immigrated 25 years previously. On presentation, his vital signs were all normal. He had coarse inspiratory breath sounds, more marked on the right side, and a distended tympanic abdomen without tenderness or hernia. He had hypoactive bowel sounds, blanching erythematous macules, 1 to 2 millimeters in diameter on the torso, and 1+ pitting edema on the legs. The stool was brown and guaiac positive. The labs were all retested, and they were mostly normal, including retesting of IgA and IgG for TTG. The urine was positive for nitrates, and he was ended up diagnosed with a UTI at that time. However, despite multiple rounds of antibiotics, he continued to have fevers and abdominal pain. And on representation 9 days later, he was cachectic with a fever of 38 and a BMI of 18. And then further studies were done and a diagnosis was made. So again, I try to condense a little bit because we're short on time, but still a lot of process there. And of course, I loved your differential, and now it kind of adds a little bit with this history of a strongyloides infection, though, just to be clear, that's partial of what's going on. So there's still a little bit going on.
Yeah, no, I love it. This is really the whole goal of this is to try to think rapidly in real time and then compare your thinking to somebody who is an expert in the space. And I think, honestly, I won't go through this in a manner that does justice to the patient and thinking about it systematically, but rather just sort of reflex association. So we get to round 2 of this. And I would say that like the progress we've made is we've heard that he's from the Caribbean, which puts tropical sprue and highlights and really emphasizes that condition. The argument against that is the fact that is a devastating disease centered on the GI tract. Patients usually aren't febrile and usually don't have any extraintestinal manifestations like the rash we see here, but it's such an easy thing to treat. And so the treatment, the treatment is, I know it's antibiotics, and I think it's doxycycline, but I'm not entirely sure. I'd have to review that, but that's certainly something that jumped in my mind. The fact that this patient is now febrile prioritizes an infectious process, and Whipple's disease comes into mind. So the fact that the IgA is normal both excludes seronegative celiac disease, but also makes CVID, common variable immunodeficiency, a little bit less likely. The strongyloides here, I think you just want to make sure that it was definitively treatment, but just goes to reinforce that the infectious risk that this patient has coming from the Caribbean. So I'm not confident about what the answer is. I think that Whipple's and tropical sprue are priority simply because the patient appears to have an infection by virtue of the fever. I think intestinal lymphoma is a no-miss thing. And I don't know what I would do as a treating clinician. I would probably consider a round of tropical sprue antibiotics, but it's easy to see how a repeat endoscopy looking at lymphocytes and Whipple's disease PCR would be a helpful test. I'll say that I ignored everything else because I think everything else is not specific enough. Like the rash isn't specific enough for me. And the abdominal distension and the edema are easily mapped onto protein losing enteropathy, which is a devastating consequence of any of these processes. So that's why I didn't really expand much on them. So everything just reinforces the GI differential, and the fever says, focus on the infections first and then move on to the other stuff.
Yep.
All right, Travis.
Great. Yeah, thanks. And thanks for, like I said, these are real, they publish these because they're challenging rare diagnoses,
100%.
right? And so the expert clinician that was invited really agreed with everything you had to say. They agreed with the repeat biopsy, which is what I ended up making the final diagnosis. And the repeat biopsy showed basically his bowel was overrun with strongyloides, which again doesn't necessarily make the diagnosis of the complete picture. And so what the expert focused on is you actually can have a hyperinfection syndrome of strongyloides if you have other immunodeficiencies. So then what would be another immunodeficiency in this patient who doesn't seem to have any that leads to a hyperinfection syndrome? So HIV being the most common, but then things like you had mentioned CVID or others, like an intrinsic autoimmune. But again, going back to where this patient was from, I guess the most common cause is HTLV1.
Yeah.
And so there's a co-infection of HTLV1 with this patient that allows the strongyloides to kind of overwhelm the system and lead to a lot of these other extraluminal symptoms like the rash and the fevers. So I just think it's like and the great thing about this is the diagnosis itself is beside the point, right? It's creating the differential and comparing your differential with what was done by the expert invited, and then the pathological discussion, which I think is just great for pathophysiology learning, and not something that I just feel like it's not something focused on a lot in a lot of other medical training, but it's really where, I mean, I'm an oncologist, so I'm a little biased, but it's where the true answer sometimes lies, right? Like you got to look at the cells under the microscope to really know. And so I think learning you can get from those cases is fantastic.
That was so cool. I think that I think that's why I love these cases and I use them all the time. I think that here it's so interesting to revisit this and say, what about this case is inconsistent with the patient having periodic hyperinfection with strongyloides? And I think the major error that I made rapidly was to say this is chronic as opposed to recurrent acute disease. And that's always a little bit tricky. I think that if you go back and you feel like, oh, this patient just kept getting bouts of this, if you reframe it as recurrent acute abdominal pain, the strongyloides hypothesis takes even more credence, as opposed to what I was trying to do, which is chronic. But that's not what you said. You said that he got discharged, hung out, came back, got discharged, come back, hang out. And so I'd say pay attention to the time course. That tends to be very variable.
Yeah.
But I think that, when you have a patient with strongyloides who comes in with fever and a rash, and it's from the Caribbean where HTLV is endemic, I think it's a great fit. So yeah, really cool case. Thank you for
I want to, if you wouldn't mind letting me share screen again, I want to go about and see how we can go from that to other like, how do we learn from this more, right?
Just so folks are confused, there's round 2. So this is go through a case that you randomly,
and that was what, talking to Dr. Dollywall, he really stressed is that he believes that learning from case-based learning is augmented when you are doing multiple cases that are similar but different, right? So can you find, you've learned it once, you've gone through it once, but now it's like practice, right? Practice is important, and reps that are synergistic are also important. So there are a couple different ways we can use the tool to increase similar reps, right? And I was just going to show a couple ones. So there are 2 other ways to search. One is this final diagnosis. And so this is basically exactly like it sounds. So it, and you can just look for strongyloides. Here it is. And again, we want to always preserve mystery, right? Like it doesn't help if you search for it and you know what the result is. It's not quite the same in learning. So what I did was create a return similar cases filter, which allows you to find cases that are similar to a strongyloides case using natural language processing and machine learning. So basically something the AI thought were similar cases based on the differential diagnosis discussion. So, there's a long section of differential diagnosis where the patients are discussed. If those 2 things are similar, those 2 parts of text, then it will return that case. Again, you want to show final diagnosis, you want to hide that, right? So you don't blow it. And so you can search for these cases, and the yellow dots in this case are ones where the diagnosis is strongyloides. And the ones around it, that's kind of where I got the idea of the universe. The ones around, so that's like the sun, and the ones around it are ones that are very similar to that strongyloides discussion, right? So I think we could probably find our case here. So this is our case, and this is a case that it thought was very similar that you can try, test your reasoning on, and hopefully they'll be very similar and kind of have similar practice. So I think that's the one we'll go over. The other way to do it, which I found interesting in a different way, is instead of searching by the final diagnosis, you search by where strongyloides was on the differential discussion. So when strongyloides was considered an option, but it may not necessarily the final diagnosis. So you can search the same way. And in this case, the size of the dot represents how strongly strongyloides was considered in the differential diagnosis, right? So the little dot, maybe it was just mentioned in passing, whereas if it was a larger dot, you know, it's described in detail. And I think, oh yeah, so I actually kept the diagnosis table here, and you can see that actually after looking at this case, strongyloides circulitis with hyperinfection is a very popular diagnosis in the CPC, despite it probably not being very prevalent in the general population, right? So they had multiple cases where strongyloides circulitis came up. I think this is the malinga that we did, but there are others. But then, of course, a lot of the other things that we mentioned came up. So pulmonary eosinophilia. By the way, what was interesting in that case, we didn't mention it, but this person did not have eosinophilia, which I guess can be common in these cases of hyperinfection because you're immunosuppressed. So you basically can't mount that eosinophilia. So the case I think we decided to go on was this 2016 case 17. So do you mind if we start on it?
100%. Let's rock and roll.
Okay, that was great. So 80-year-old man with weight loss, abdominal pain, diarrhea, and an ileocecal mass. So 80-year-old man with end-stage renal disease, type 2 diabetes, peripheral artery disease, hypertension, coronary arteriosclerosis, congestive heart failure, abdominal aortic aneurysm, and hyperlipidemia. Got admitted to this hospital because of anorexia, weight loss, abdominal pain, diarrhea, and an ileocecal mass.
Oh my God. It's like, I can't believe you're keeping up with this. So impressive.
Yeah, sorry, I probably could have condensed that.
Keep going. Yeah, it sounds like
yep. So the history actually started, and this is why I apologize a little bit, Ravi, is like, I was interested in pancreatic cancer, so I picked these symptoms, but then in retrospect, I'm like, weight loss makes these cases really long, right? You end up picking chronic cases. So it started 3 years ago with the development of a node in the left upper lobe, FDG positive node in the left upper lobe that progressed to nodes in the right middle lobe and pleura over the next 5 months. There was also increased FTG avidity in the stomach and ileum. A biopsy was recommended, but the patient refused. 2 years subsequent to that, patient developed severe abdominal pain in the right lower quadrant and right flank. CT on hospital admission, on emergency room, showed a hematoma and an RP bleed, pararenal hematoma and an RP bleed. The soft tissue mass had increased in size. The bleeding was stopped with embolization, and a colonoscopy showed a fungating mass at the ileocecal valve. Biopsy of the mass showed severely active chronic colitis with fibrinopurulent exudate. EGD also revealed several foci of erosive gastritis and reactive foveolar hyperplasia and non-necrotizing granulomas. No fungal forms or acid-fast bacilli were seen on either biopsy. Patient was DC'd on omeprazole, but follow-up labs were notable for an ESR of 67 and a CRP of 55. I was thinking about stopping there, just again, because there's a lot. I can keep going or give any details that are missing.
I'll just share. I would love for the chat to share your thoughts. I think that solving this case quickly. You're like, what's the differential diagnosis of a mass? It's cancer until proven otherwise, and it has been proven otherwise by the fact that the biopsy does not show any malignant cells. The question is, how good is that biopsy? And it's pretty good, but of course, sampling error and cryptic cancers are still loom large. But the key word that Travis said was he has fibrinopurulent exudate. That is a buzzword for infection and a buzzword supported by the presence of granulomas. And so then it becomes, what are the infectious causes of an ileocecal mass? And worldwide, I would say tuberculosis is by far and away the most common, followed by histo and paracoxy as chronic masses. The most notorious mimicker is Entamoeba histolytica, which usually is associated with subacute disease that can cause chronic disease. However, I'd say that the chronicity of this and the chronicity of this being 3 years is a powerful clue. And if it's not TB, it's probably actinomycosis. So those would be my leading considerations: is make sure it's not TB, which there's no test under the sun that can prove it's not TB. but actino is an actionable hypothesis, but it requires very specific staining. So I think the data here is suggesting infection, which is unusual. Usually these things are cancers. And the question is what kind of infection?
Yep, I think, again, fantastic, kind of diving into how to think about the case. I will just continue, and then we can kind of discuss.
Yeah.
Continued to have an intermittent severe abdominal pain and diarrhea, continued with weight loss, with the pain being centered in the right lower quadrant. A diagnosis of Crohn's was considered, and actually a recommendation of treatment with prednisone and methotrexate was recommended, but the patient declined, refused treatment. Over the next year prior to diagnosis, patient was admitted for sepsis multiple times with low-grade fevers, and thought potentially due to chronic C. diff, as he continued to have positive C. diff despite treatment. However, the fevers and melena and bright red blood continued despite treatment and clearance of the C. diff. CT scans continue to show wall thickening of the terminal ileum and cecum with fat stranding. Finally, on the day of presentation, patient was brought in with shortness of breath. He reported progressive fatigue and weakness to the point of being unable to get out of bed. So talking a little bit about past medical, he had immigrated from Southeast Asia 22 years ago and lived with his wife in the Northeast. He had a negative family history for renal disease or inflammatory bowel disease. Also notable, he did have a positive PPD to 8 millimeters during the start of his dialysis treatment, which was about 5 years previously. His vital signs were stable, but with slight tachycardia, crackles in posterior lower lung fields, and abdomen was tender and legs edematous. However, the patient's shortness of breath and legs did improve with hemodialysis, but during the admission, a diagnosis was made. Honestly, I don't think you needed any of that additional information. I think you kind of nailed the diagnosis prior to any of that. But I think just showing the chronicity and the progression of this disease is kind of important. Again, what I love is we don't always have Robbie to kind of go through what a great differential for this would be. And so they go through a very similar differential. I think, like they said, tumors potential. I think they mentioned a lot of the same infectious etiologies that you had. And then, IBD, though, I will say that despite them talking about Crohn's disease a lot, I don't really feel like it fits as well as some of the other things we have discussed, especially towards the end, with these kind of low-grade fevers and so the diagnosis was intestinal tuberculosis. And again, this kind of does fit with the FDG avidity, right? From a cancer perspective, there are not a lot of things that start in the lungs and move to the small intestine. Now, you could say maybe this was a small intestine tumor that then metastasized to the lungs, but with the FDG avidity, but we don't, the ileocecal valve isn't a common place for these kind of tumors, and going to the lungs without other kind of widespread signs of disease and then a negative biopsy would be super rare, right? So I think you were right on and kind of like dismissing, looking for other sources of a mass given the negative biopsy.
Strongy and TB cousins, as you've now proven.
Right.
What we should do in the last few minutes is just see what questions folks have either about the case, but more importantly about how they can use this incredible online tool that you have. But first, let's dispel one quick thing. Travis, can you tell us how much it costs to use your app?
Oh, yeah, sorry. Yeah, it's free. Yeah. So just to be clear, it's free to use the app. The cases themselves still require New England Journal of Medicine access. Most of us have that through our academic institution or whatever medical center we have. But it's their intellectual property, right? So the goal is to use this tool to identify a case, and then it links you directly to their site so that you can read the case and learn from it in full.
Awesome. Questions, folks? Anything come up for y'all about? Yeah, I don't know. Alec, do you want to ask your question out loud? I wonder if people are wondering it.
Yeah, I have thought about this. So there are a lot of great case series that this would fit, and there's I think the biggest challenge is I would want at this point I would want some sort of interesting collaboration. So before I did any of this, because I used data from the New England Journal, I reached out to them directly and said, can I use your data? Like, I don't want to go through all this work just to have at the end, then say, you know, we don't want anyone accessing outside of our main portal or firewall. And it actually, one of the longest parts of this process was talking to them and kind of coming to agreement about what would and would not be acceptable outside of the firewall. And this is the agreement we came to. So the analyses are all very portable to other systems, to other case series. Now, there are slight differences in the structure, right? So the biggest challenge is making sure that we have the structure correct, so that we aren't misinterpreting, for example, what presentation of cases in the section, things like that. But at one point I was very excited about this expansion, but given my other research, like it would need to be a collaboration with whoever, other case series. Just talking more generally, I'm not sure, I'm assuming that most of the people on this are internal medicine focused. But for the medical students here, one thing about the CPC I noticed going through it, the New England Journal CPC, is I think it's quite, it has biases, right? In what it covers and what it does not cover well. Obviously, from the internal medicine side, it covers rare diseases and rare presentations of common diseases, which is fine. That's its goal, right? I would say one thing it does not cover very well is OBGYN and to some degree pediatrics. Now, if you're in internal medicine, I think that's okay, right? But I just want to think about that is like one of the things I was thinking about if I wanted to expand this to be like for medical education generally would be an OBGYN journal or a pediatrics journal, where I feel like there's limitations from the CPC on those particular fields. But those were, and then, I'd also thought about expansion to other subspecialty journals, like the more data you get, the more refined you can get in your analyses. And that's kind of just a general principle. So if you got the same number of cases just from the journal CHEST or just from Journal of Clinical Oncology, you could really dive into the distinctions between different presentations of cases, which, would be exciting from an academic perspective. So no immediate plans, but if anyone has contacts at those journals, I'm happy to talk to them about it, but it would have to be more than just me at this point. Yeah.
Travis has done probably 10,000 hours.
Yeah.
Work on.
I was like, at some point, I probably could have just been a consult service, and I could find the cases for you by myself.
Amazing. Well, thanks y'all for coming and hanging out. Thank you, Travis, for sharing this incredible free tool with all of us. We're really excited to use it. I use it all the time, at least once a week. And I'm excited to expand that. And thank you for doing good in the world of clinical reasoning. And thank you guys for sharing this hour with us.
Yeah, thanks so much for having me. It was great. And, it just, for me, it's just, it's all payback if people actually find it useful. So,
for sure.
As long as people are using it, I'm very happy and excited that I was able to do it.
We're delighted to share this with you guys. All right. Happy Friday. All enjoy. See you tomorrow if you're able to join the incredible CP Solvers team recap this week. I don't know who's up for Friday. Good luck to you for these really. I think it's Madalena. Isn't it Madalena? Our scribe from today had to scribe at 10 million miles an hour and then teach about this tomorrow. See y'all. Take care.